Hello, everyone. I'm Dr. Sushant Srivastava, an assistant professor in Department of Orthopaedics, Mata Gujri Medical College and Lion Seva Kendra Hospital, Kishanganj, Bihar, India. I'm here to talk about intertrochanteric malunions and nonunions. I have no disclosures. So, intertrochanteric fracture is one of the most common fractures around the hip, especially in the elderly due to any trivial trauma. Now, this is encountered by almost all orthopedic surgeons. Hence, appropriate knowledge of the relevant anatomy and classification is very important. There is no consensus as such on the best classification for an intertrochanteric fracture. Hence, it's important and essential to have an in-depth knowledge of the relevant anatomy and various classifications. So that's why we are going to dive in straight here. So here on your screens, you have the relevant anatomy of the proximal femur, wherein we are going to focus on these two things. That is the blue line, which signifies the pertrochanteric region, and the red line, which is the intertrochanteric region. So our talk today is going to talk about fractures around the intertrochanteric region. As we can see, the proximal part of the femur is consisting of the head, the neck, the intertrochanteric crest, and the part just below, that is 5 centimeters, which is also the subtrochanteric region. Now going to the relevant anatomy, or the anatomy which is very important in the proximal part of femur, and which comes into the picture whenever you have any intertrochanteric femur fracture. So the bony configuration of the proximal femur with hip joint is one which has to be considered. You can see the head, the neck, the intertrochanteric line with the greater trochanter and the lesser trochanter, which is the anterior view. When you go posteriorly, you can see the intertrochanteric crest with the pectineal line. The neck shaft angle is 130 degrees plus minus 7 degrees. The anteversion is 10 degrees plus minus 7 degrees. The intertrochanteric area exists between the greater and the lesser trochanter. The average radius of curvature of femur is 114 to 120 centimeters. Now, we need to understand that the bone density goes on decreasing with age, and it's one of the major causes of increased bowing in elderly. So, in the old literature, there was a lot of talk about Adam's arch. So, what is this Adam's arch? The Adam's arch is present on the medial part of your intertrochanteric region. There were more amount of research done, and then they got to understand that this area which encompasses along with the Adam's arch is actually the calcar femoral. So this diagram actually gives you a proper perspective and view of the Adam's arch and the calcar femoral. But why am I stressing on calcar femoral? Because calcar femoral is a vertical wall of dense bone that extends from the posteromedial aspect of the femoral shaft to the posterior portion of the femoral neck. The bony anatomy helps to know the level of the involvement of the intertrochanteric fracture, and this also helps to determine whether the fracture is a stable or an unstable fracture pattern. Now, with the bony anatomy done, let's dive in straight to the muscular anatomy. One should remember that the deforming forces acting in an intertrochanteric fracture exist on the proximal as well as the distal segment. Now, the proximal segment, what happens is there is a flexion, external rotation, and abduction. Now, these are caused by the deforming forces of the flexors, that is the iliopsoas, sartorius, rectus femoris, and pectineus. The external rotators, that is the piriformis, superior gemellus, obturator internus, inferior gemellus, and quadratus femoris. And the abductors, that is the gluteus maximus, gluteus medius, minimus, and the tensor fasciae lata. So the diagram here tries to encompass the muscles which act on the proximal segment during an intertrochanteric fracture and bring about the flexion, external rotation, and abduction. The main deforming forces on the distal segment, they bring about the adduction and shortening, which is due to the pulling effect of the adductors. So we need to understand that the medial compartment, that is the adductor compartment, consisting of the adductor longus, brevis, and magnus, along with the gracilis, which is traversing from the hip joint right to your knee joint, are important to give this pulling effect to the distal segment, which is then in a adduction and a shortening form. Now, apart from the muscular anatomy, we come to the blood supply. Now, intertrochanteric area has a very rich collateral circulation. We are going to talk today about the malunion and non-union. So just to give you a caveat, non-unions in an intertrochanteric fracture is very rare and very less published because of this. That is, it has a rich collateral circulation, which reduces the risk of non-union. Now, it receives its supply from three sources: the trochanteric anastomosis, which is made up of the ascending branch of the medial circumflex femoral artery, the ascending branch of the lateral circumflex femoral artery, and the deep branch of the superior gluteal artery and inferior gluteal artery. There is a transverse branch between the lateral circumflex femoral artery and the medial circumflex femoral artery, and also the blood supply from the periosteum and surrounding muscles. Now, this diagram here gives you a schematic view of the rich collateral circulation around the proximal femoral area. Now, the biomechanics. So before we go ahead for any complication, you need to understand the biomechanics or the problems which are happening in an intertrochanteric fracture. So whenever an intertrochanteric fracture occurs, first the abductors pull the GT proximal, which can be seen here with the orange arrow. The iliopsoas pulls the lesser trochanter proximally and medially. The adductors, the ones in the medial compartment, they pull the shaft medially, and the short external rotators cause an external rotation deformity. So, in a case of intertrochanteric fracture, you see a coxa vara, a prominent greater trochanter, shortening and external rotation deformities. Now, after going through this anatomy and the biomechanics of this fracture, let's delve in straight into the classifications, because this will give you an idea about the amount of work which has happened in intertrochanteric fractures over the past 7 decades. So the most popular and the most used classification is the AO trauma classification, but there has been an evolution right from 1936 to 1979, which is called as the older classification, and the recent past, wherein there have been 2 new classifications coming in. So the one which we all are aware of and have stood the test of time is the Boyd and Griffin classification, which divided the intertrochanteric fractures into 4 types. Type 1 being the fracture that extended along the intertrochanteric line. Type 2 is the comminuted fracture with the main fracture line along the intertrochanteric line. Type 3 was the fracture that extended distally to the lesser trochanter, and type 4, the fractures of the trochanteric region and proximal shaft in 2 planes. Then came the Tronzo's classification, wherein the fracture was divided into 5 types. Type 1 was an incomplete fracture. Type 2 was uncomminuted fracture with or without displacement. Type 3 had 2 things. One was a comminuted fracture. The larger greater trochanter and the posterior wall was exploded. And type 3 has a variant wherein the greater trochanter was also fractured and was separated. In type 4, the posterior wall exploded and the neck spine displaced outside the shaft. And type 5 consisted of the reverse obliquity. And this was spoken by Tronzo. Then we have the Evans classification, which gives the basic premise of the stable and the unstable intertrochanteric fracture. So type 1 was a stable undisplaced fracture, which also consisted of undisplaced but reduction overlapping of the medial cortical buttress. Type 1 had an unstable displaced, but the medial cortical buttress is not restored by reduction, or it's displaced and comminuted fracture, which is not restored by reduction of the fracture. Type 2 was unstable and reverse obliquity. So you need to understand that in the Evans classification, there were two types, type 1 and type 2. Type 2 has unstable fracture, which is reverse obliquity. So Tronzo, the type 5, is type 2 in Evans classification. Now, Jensen gave a modification of the Evans classification wherein he spoke about the type 1 stable, displaced or undisplaced stable two fragment fractures. So if you can, try to understand here, this is the Jensen's modification of the Evans classification, and type 2 is the unstable three fragment fracture with greater or lesser trochanter or four fragment fracture. Then we had the Kyle's classification. Now, Kyle directly divided type 1 and 2 as stable fractures and type 3 and 4 as unstable fractures. So type 1 and 2 stable fractures, fracture consisting of non-displaced stable introchanteric fractures without comminution, fractures representing stable, minimally comminuted but displaced fractures. Type 3 and 4 were unstable fractures wherein there was a problem fracture and a large posteromedial comminution in the area in type 3. And type 4 fracture was uncommon and it consisted of a subtrochanteric component. Now the modern classification, that is the AO or the Muller classification and the G.S. Kulkarni et al. Classification in 2007. So this is the AO classification, which is widely used all around the world. So just to run through this, we all know if it's type 3-1A. So bone, femur has the number 3. Segment is proximal, hence the number 1. Site and trochanter is A. And there are three types, that is A1, A2, A3. So type A1 is a simple two-part fracture, which you can see in the proximal row. Type A2 is a fracture which is comminuted with a posteromedial fragment and the lateral cortex of the greater trochanter remaining intact. That is A2 fractures. And type A3 are the fractures in which the fracture line extends across both the medial as well as the lateral cortices. And this group includes the reverse obliquity and the subtrochanteric extensions. And each type has A1, A2, and A3, which is further divided into three subgroups. So this is the table which is showing us 3-1-A1 peritrochanteric stymple, which is stable in its stability. The description along intertrochanteric line through greater trochanter, below lesser trochanter. Peritrochanteric multifragmentary, stable with one intermediate fragment, unstable with several intermediate fragments and extending more than 1 centimeter below lesser trochanter. Intertrochanter 3-1-A3, unstable in stability and having a simple oblique, simple transverse and multifragmentary part. Now, Dr. G.S. Kulkarni et al. Gave a classification wherein he showed the type, stability, character and the clinical relevance in which implant has to be used for the fracture fixation. So his classification has type 1, type 2 and type 3, wherein 1 is divided into 1A, 1B and 1C, 2A, 2B, 2C, 3A, 3B and 3C. So type 1, 1A is stable undisplaced, 1B is stable minimally displaced and 1C is stable minimally displaced with a small fragment of lesser trochanter. All these fragments or all these fractures, beg your pardon, can be managed by any fixation modality and it gives excellent results. DHS is the implant of choice here. Type 2, A, B and C. Now 2A is unstable 3-piece fracture, 2B is 4-piece fracture and 2C is IT fracture with a shattered lateral wall. These unstable fractures are defined as the problem fractures by the group and they can be managed with DHS with some modification or an intramedullary nail. Type 3A, that is the trochanteric fracture with extension into subtrochanter. 3B, that is reverse obliquity, and 3C, that is trochanteric fracture with extension, is the unstable fracture with DHS, and it gives poor result. So intramedullary nail is the better choice as they prevent extensive collapse. Arthroplasty can also be done in select cases. Now, this is just a demography as to how much intertrochanteric fracture is affecting the world. Now, this data was published way back in 2012, that is almost 12 years from now. But if you look and see, even 10 years back, this was how things happened. Now, the red colors shows 250 fracture types every 1 lakh people. Orange is the countries having 150 to 250 patients of IT fractures per 1 lakh, and the green zone shows less than 150 patients per 1 lakh population. Now, intertrochanteric fractures. So, intertrochanteric fractures are almost 50% of the hip fractures. The complications are non-unions and malunions, but they are relatively uncommon. They are uncommon because of an excellent blood supply and good cancellous bone in that region. Occasionally, non-union or early failure of fracture fixation occurs. This is due to delayed treatment, unfavorable fracture patterns, poor bone quality, or suboptimal fixation. Now, non-union is something which results in pain and functional disability. Literature is sparse regarding the primary intertrochanteric non-unions and its treatment. So, revision internal fixation is to be done, in which two things have to be remembered. Now, when you're treating an elderly, hip arthroplasty is to be preferred for the intertrochanteric non-union with a damaged articular surface or inadequate bone stock. So we had this case of a female who came to us, within 6 months, and this was a sort of a non-union, wherein we went in, did a bipolar hemiarthroplasty with K-wire holding the GT, which we did not shave off completely, with the help of a cerclage, SSY. Then in physiologically young patients, preservation of the femoral head is preferred. This case has been given by Dr. Sachin Kale, a professor in Devai Patil and my mentor. So in this, the case, if you see, this was a non-union of the intertrochanteric femur fracture, which was treated with a DHS screw and bone grafting. Another case which we treated in our hospital, wherein the fracture was a non-union and was used and treated with a valgus osteotomy and DHS plate. Now, in cases of intertrochanteric fractures, malunion. So, malunited intertrochanteric fractures are basically seen in rural populations. Why is it so? Is because they go in for native treatments with traditional bone setters. Now, let me tell you a little bit of a perspective as to where I'm coming from. Kishanganj is a tier 4 city in the state of Bihar in India. So we have maximum amount of patients coming from rural areas to us. The amount of intertrochanteric fractures with malunions I see comprise approximately 60% of my daily OR time in a month. So they present late to us due to various factors. Most of the population are from a lower socioeconomic group. Many are manual laborers who depend on daily wages for their sustenance. Now, there are various factors. One is lack of affordability of the treatment which is given. And the second is a deep-rooted traditional belief in native bone setters, which makes them go for a native treatment. Now, this is an example of a case which I see oftenly in my OPD. So you will have this patient walking in inside at 8 months with this sort of X-ray with you. So we all know this is a malunited intertrochanteric fracture. Now the period of native treatment goes around from 6 weeks to 8 weeks. There is also a history which is of a massage or a manipulation. There is a risk of development of myositis ossificans, which again gives us a different set of challenge. The intertrochanteric region is composed primarily of cancellous bone. So the fracture tends to unite well, albeit in a non-anatomic manner, leading to a malunion. So if you see this fracture here, there is some callus formation which has happened in the medial part. The lateral part is opened up, and the patient was walking when he came to us. Now, you will come to understand as to why they come for the treatment. So, the resulting coxa vara is the problem in these patients. They have shortening, they have external rotation deformity, which limits their abduction and internal rotation. There is limping and issues of hip and back pain due to these mechanical factors. Now, what happens primarily in this part of the world is there are two activities which are of paramount importance to the laborers or the daily wage earners. One is squatting and other is sitting cross-legged. So in the Indian tradition or the Southeast Asian tradition, squatting is a very important thing which is done for the purpose of defecation. So when this is lost, patients have issues. Also, patients who are not able to sit cross-legged for sitting on the ground and partaking meals, that is also when they come to us in the OPD. And that is where the whole cycle starts. So the ideal treatment mentioned in literature has been total hip arthroplasty. But for the given geographical and demographical region which I come from and this place is, it's not the ideal situation. It's expensive for them. Even if they are not having a particular Yojana card which is used in this part of the world, they cannot afford it. There is an avoidance of squatting and sitting cross-legged following arthroplasty because of the low quality implants being used for the arthroplasty. And it would not be feasible for these patients who present to us from the rural population. Now, I'll show you cases wherein we have gone ahead and done normal routine procedures using a proximal femoral nail, wherein this 49-year-old male having a 3-month-old fracture, we went in, took a good alignment which was seen on the C-arm, and then we put in a intramedullary proximal femoral nail. This is another female, 5 months old, with a shattered greater trochanter extending to the medial cortex. A proximal femoral nail, that is a trochanteric femoral nail, was done. Then we had this case, which was 6 months old, and there was a complete shattering of the medial wall as well as the lateral wall. So somehow we could gain an entry inside, and we just held on to this with the SS wire. Another case of a 80-year-old female who presented to us 1 month after the fracture. Entry was done and a trochanteric femoral nailing was done in this patient. So we, in this part of the world, have tried to set an algorithm for the management of intertrochanteric fractures. Now, if you see, if there is a failure in the union of the intertrochanteric fracture, check for two things: whether there is a telescopy which is positive, or if there is a movement at the fracture site on traction. If that is yes, that means it's a non-union. And if you can't see any of these two things, it's a malunion. So if it's a yes, it's a non-union, then you check for an infection or whether there is no infection. Now, if there is an infection, you go ahead, do an internal exploration, debride it, put in some local antibiotics and a bone cement, and wait for 6 weeks for this infection to subside. When this happens, it again comes back to our group of no infection. wherein we use a bone graft in partial metaphyseal bone loss. Then, if there is a lateral wall thickness of more than 20 mm, lateral wall thickness less than 20 mm, and grossly altered anatomy, arthritis, and osteoporosis. So these are the three things which you will be seeing here. So now you'll go ahead and do a sliding hip screw or a cephalomedullary nail in a lateral wall thickness more than 20 mm, lateral wall thickness less than 20 mm with shattering, 95-degree angle blade plate with a cephalomedullary nail, and grossly altered anatomy or arthritis and osteoporosis. One needs to go ahead and do the salvage total hip replacement. Now, this was for the non-union. We'll go ahead with malunion. So, patient comes in with a malunion. You will check for infection, follow the same pattern of internal exploration, debridement, and antibiotic bone cement for 6 weeks, convert it into the non-infection group, and then go ahead and see whether the malunited fracture has a head shaft angle of less than 90-degree. If yes, please go ahead and do a sliding hip screw or a 110, 120-degree angle blade plate. We do a valgus intertrochanteric osteotomy in such patients. If it's a maluniting fracture, head shaft angle is achieved after osteoclasis and the head shaft angle is less than 90-degree. Check whether there is a lateral wall thickness of more than 20 mm and a lateral wall thickness less than 20 mm. In case of lateral wall thickness more than 20 mm, do a sliding hip screw or a cephalomedullary nail. Lateral wall thickness less than 20 mm, do a 95-degree angle blade plate with a cephalomedullary nail. This is a landmark paper given by Bhomik et al. From the Hip International Journal. Now, there are three important technical points which one needs to remember. Sorry. So, what do you know or mean by a negative reduction, neutral reduction, and positive reduction in intertrochanteric fractures reduction? So, negative reduction, the beak of the neck is inside, which leads to the varus collapse, and it's not preferred. A neutral reduction is that the beak of the neck sits on the medial cortex of the distal fragment and is acceptable. And if the beak lies medial to the medial fragment, that means it's a positive reduction and it's preferred. So there are important pointers which I have put down for one to understand how one should go ahead with the intertrochanteric femur fracture fixation. Good anterior reduction and temporary fixation by 2K wires. Good medial reduction, that is a positive cortical reduction. The entry point has to be in line with the medullary canal. The neck screw placement has to be perfect. The neck screw should be placed as subchondral as possible so that the calcar tip apex distance is less. We all are aware that it should be less than 25 mm. Compression of fracture should be achieved on table. There should be a little bit of a nail projecting at the entry site, and dynamic locking should be done in all the nails whenever possible. Now, I have put in three important papers which I came across and everyone should read. One is the Intertrochanteric Fractures, 10 Commandments for How to Get Good Results with Proximal Femoral Nailing by B. Shiv Shankar and Sanjay Keshkar. Intertrochanteric Fracture, Relevant Anatomy and Classification by Ratnesh Kumar et al. Decision Making in the Management of Malunion and Non-Union of Intertrochanteric Fractures of the Hip by Kaushik Bhomik et al. I wish to pay obeisance to my gurus in trauma. I come from a land which has given lot of ingenuity and newer workforces through all these people. That is Professor D. D. Tanna, G. S. Kulkarni, S. S. Babulkar sir, Dr. Vasudev Gadegone, B. Shiv Shankar, Professor J. Dindayalan, Shushut Babulkar, Nilesh Joshi sir, Srinivas Kasha and Shailesh Pai. I would be failing if I don't thank Professor and Head of Unit Dr. Sachin Kale sir, who has been a mentor and helped me prepare this presentation by his constant encouragement and constructive criticism. I come from a place called as Kishanganj. I am a born bred red boy from Mumbai. I went there to do a bit of research and orthopedics, and this was the place where I found myself again. I thank you all for a patient listening. Godspeed.